So students, in the morning classes, we had discussed about the very basic and very general understanding of leukemia. And if you have really understood those basic concepts of leukemia, what I was showing from lymphoid and from myeloid lineage, how the cells grow into many specialized functional cells, how they differentiate, and what is chronic, how will you define the chronic and acute stays in that lineage. So if you are able to understand that concept, this will make your job a lot easier in understanding the sign and symptoms of the acute and chronic leukemia, even the treatment, okay, and even the diagnosis part. So that was very much important concept. I hope all of you grasp. If you have any confusion still remaining, you can ask me. I'm open for that. But if you have already understood that, things are going to be a lot easier now. Concepts are not that tough. You just have to understand about the regimen, drug, and how the treatment protocol goes. So am I clear in the morning class, the general brief introduction on leukemia? Everyone?
Yeah. Yes, sir.
Okay, so we talked about the brief definition of leukemia. We talked about the classification where I told acute and chronic, and again in acute and chronic, if whether it is from myeloid line or lymphoid line. So that's going to be different. That are going to be different. And then we started discussing about acute leukemia. We discussed definition, types, and groups. We also discussed the morphological classification of acute leukemia based on their morphology. So now this is what we are supposed to start now. The etiology of acute leukemia. So these are very some of these are very general things. Some of these are the concept that we have already discussed in the cancer general principles, and the normal anti-cancer drug that even you read in your MC and pharmacology. So number one reason is drugs and chemical. So you know that I think I had told sometimes back in the class that all anti-arrhythmic drugs can cause arrhythmia, and all anti-cancer drugs can cause cancer. You remember?
Yes, sir.
You remember? And I have also explained the mechanism how it can cause that. For example, you know you are using a drug on a normal cell, but the function of that anti-cancer drug is to manipulate and modulate the cell division. So normal cell is dividing at regular pace, but if you are using an anti-cancer drug, then definitely the normal cell cycle is going to be disrupted. So that's how that drug gonna cause you gonna cause the patient to suffer from cancer. Some of the common examples are alkylating agents like chlorambucil, nitrogen mustard, mephalan, and topoisomerase inhibitor like etoposide. These can cause cancer. Some of the chemicals like benzene that we often use in our labs, even that can cause cancer. Okay, those are carcinogenic chemicals and the drugs. Sometimes ionizing radiation can cause cancer. Ionizing radiation, maybe it may be UV radiation, it may be many other kind of radiations. Sometimes the virus, okay, HTLV is human T-cell lymphotropic virus type 1. This is also called as human T-cell leukemia type 1. And this virus is implicated in several kinds of disease, including tropical spastic paraparesis. And this virus, STLV1, serves as important link between cancer and leukemia. So in cancer, virus is something very interesting that has role actually. Can you remember anything else related to cancer and virus? I think I have discussed some concept of cancer and virus in the general principle of chemotherapy. Anybody here? Anything that you can relate cancer and virus? Yes or no?
No, sir.
Okay, so I will help you here. Okay, at least I have taught you AIDS, right? HIV/AIDS.
Yes, sir.
Okay, in HIV/AIDS, have you discussed anything about cancer, Swastika?
I don't remember, sir.
Rajan?
Not remembering, sir. That
Okay, anybody? Aishwarya?
No, sir.
Okay, what is KS? If you have really gone through my slides, you will remember. You will recall. Kaposi sarcoma, have you heard of it?
Yes, sir. Opportunistic infection.
Kaposi sarcoma is a post infection in HIV, and it's a cancer, right?
Yes, sir.
So when I asked you what is the can you find any relation between virus and cancer? So this is one thing that should come from your curriculum because you have read this. So there is something called oncolytic virus, okay, in immunotherapy. So now people are manipulating this virus to treat the cancer. Okay, so they are taking the virus, they are engineering the virus, they are manipulating their DNA. Then they are putting that virus into the host cells, and these viruses have very specific, very target kind of nature. They go into only cancer cell, and there they multiply and they kill the cancer cells. Okay, by using the host immune system. So that's why the immunotherapy, and these things is growing now. These kind of immunotherapy are growing science now because you see we have many treatment for the cancer, but almost like all the treatment of the cancer we have some other kind of side effect because they do also target on a normal cell. But this immunotherapy or this oncologic virus, they target only the cancer cell. Okay, and we have, but even FDA have they approved the treatment for melanoma, which is skin cancer, and then um, there is a potential that it can even treat breast cancer, it can even treat pancreatic cancer, colon cancer, and glioblastoma, the cancer in the brain. So this is something emerging. Okay, and this has happened now. This science has been translated just based on this basis, that the link between the virus and the cancer. Okay, so there is a link between virus and cancer, and then some of the genetic disorder can cause you Down syndrome, can cause you acute leukemia. The genetic disorder like Down syndrome. Do you know what is Down syndrome? What is Turner syndrome? I think in your +2 you might have read already. Down syndrome, Turner syndrome, these are chromosomal disorder where there is extra pair of gene or some deletion in gene. Okay, so these are extra pair of gene. Then myelodysplastic syndrome. You know, myeloma is to bone marrow, and dysplasia happening over there. So that's a myelodysplastic syndrome can cause acute leukemia. That are some of the causes, etiology of acute leukemia. Coming to the presentation, sign and symptoms. Usually for first 3 months, like usually 1 month to 3 month history, there will be myelodysplastic like syndrome, and it can even last up to 1 year. If you see in the bone marrow smear, you will find a feature of bone marrow failure. Okay, and mm, patient will, because of that bone marrow failure, patient will have low hemoglobin, so patient will feel fatigue, malaise, and because of that, some patient may even feel dyspnea, difficulty in breathing, and if and now see, all these things will make sense to you because you know that myeloid lineage and lymphoid line, and you know the ultimate cells that was going to be formed. So I think now all these things make sense to you. So bone marrow failure because the replication or the matured cell is not getting produced into the peripheral blood. So because of that, bone marrow has failed to do its function. So because of lack of RBC, there is anemia, and these symptoms has happened. Similarly, because of low platelet, there is easy bruisability. There is high tendency to get bleed from nose, from mouth, from gums, and for any dental procedure. So because of decreased WBC count, there is high chances of getting infection. So I think all these features, all these signs, symptoms make sense to you now better, isn't it, Razan? Patient can have also bone pain. Okay. Some of the signs are paler, and you know the reason why. There can be hemorrhage from the gums, epistaxis, or the hemorrhage from the skin fungus, hemorrhage from GI tract, hemorrhage from urinary tract. There can be the symptoms of hepatosplenomegaly, or the inflammation of the lymph node, or gum hypertrophy, or skin infiltration, in particular in M5 phase. The patient can have many kind of infection, many kind of sepsis, like pneumonia or periductal infection. So the patient will have fever. Differential diagnosis means what are other disease that looks like ALL, okay, that are very similar to ALL. Aplastic anemia, okay, when you read the types of anemia in your next year therapeutics, you will see aplastic anemia is anemia where which is very much related to, again, suppression of the bone marrow, where the bone marrow is not able to produce. So this looks very much like aplastic anemia. And similarly, myelodysplastic syndrome, it will look very much closer to myelodysplastic syndrome. Multiple myeloma, you know what is multiple myeloma, is disease where you have the degeneration of Schwann cells and those, what is that called? Schwann cell and what is that called? Anybody? Which helps in speeding up the neuron, transmission, neuron information impulse from one neuron to another. What is that called, Mahesh?
Neurotransmitter.
No, you know, so there are two types of neuron. One is myelinated, myelination, that is the name itself says here. Okay, one is myelinated, other is not myelinated. So this myelination will not be there in case of multiple myeloma. There is destruction of this myelination. So this may also look like this multiple myeloma, and this may also look like lymphomas. Okay, and I will in the coming discussion you will get to know what is the clear picture of leukemia and lymphoma or leukemia reaction. Then severe megaloblastic anemia. Again, this is the type of anemia which happens simply because of B12 deficiency. This picture, this ALL picture, will very much resemble like megaloblastic anemia and leukemia reaction. Anyone? Leukemia reaction? Mahesh? Mahesh is there?
No, sir.
So leukemia reaction in the morning, do you remember I was telling you the reactive increase in WBC and neoplastic increase in WBC? Do you remember that?
Yes, sir. Yes, sir.
Okay, good. So this leukemia reaction is not a neoplastic proliferation. This is reactive proliferation of the WBC. So this leukemia reaction will look like, okay, there is a very high amount of WBC, but this will not be because of cancer. This will be because of normal reactive process of the body immune system, body WBC to fight against some crisis, some ongoing active infection. So that's a reactive leukemia reaction, or reactive proliferation of the WBC, which would be like differential diagnosis of ALL. Coming to diagnosis, some of the lab tests. In CBC, what you will see, of course, you will see decrease in the WBC count. Again, I'll come back to the WBC count. Decrease in and RBC, decrease in thrombocyte, the platelet. In WBC, you may see high normal law. Why it is like that? Can anyone figure out why high normal low but not always high, or but not always low? Because now you know the pathophysiology, now you know the reason for acute and chronic leukemia. You can tell, I think. Divya, do you remember?
No, sir.
Remember when I was telling in the morning, there are different lineages. Okay, there are different lineages. What are those? Myeloid and lymphoid. Okay, so in myeloid, again, you have three things. three or four thing, and again you have two thing in your two different cell lineages in lymphoid. So the outcome is going to depend on the amount of nutrients or amount of raw materials to prepare these cells. So if once one line is hastened or increased in the synthesis of one kind of cells, definitely there won't be the raw material available for another kind of cells, right? So, if other cells are if one line is working at a very high rate, then definitely you may find a low amount of cells in the other lineage. So that's why it can be sometimes high, normal, or low. Okay, in the population study, you will see DIC. What is DIC, Rajan? What is DIC? Disseminated intravascular coagulopathy. Okay, so this is again kind of coagulation disorder where you will see the consumption of platelet in the fibrin and all. So because of that, there will be thrombocytopenia, severe thrombocytopenia, and many kind of coagulation syndrome symptoms. So coagulopathy, this is called coagulopathy. Then this may also you may see in M3 kind of morphology. Then biological study you can do urea, electrolyte, LFT, even that will give us the important picture. So that is the reason even after chemo they will do this test as a routine test. Like after first cycle they will see the CBC, LFT, and clinical symptoms, all these things. In peripheral blood smear, there will be blast in almost all the cases. Blast means, I hope you know, these are immature, fast growing, fast rapidly dividing cells at the early stage. These are not that functional. In bone marrow examination, you will see more than 20% of the blasts. Okay, so these are the typical feature of ALL. Okay, acute lymphocytic or lymphoblastic leukemia. And this is another kind of test, flow cytometry, where you will see the cytogenetics of the cell. So, and you can figure out the surface immunophenotype of the blast cells. So then you can also go for cytogenetics, where you will see the chromosomal analysis. In the coming coming part of my lecture, you will see the importance of chromosomal analysis in leukemia. Okay, so then you can also go for CSF analysis in ALL patient and in some AML patient, acute myeloid leukemia. Why CSF analysis? Why CSF analysis? These leukemia sometimes go and manifest as meningeal leukemia. Okay, this can affect the brain. So that's why the CSF analysis is important, and there they look at all the component of whatever we have seen in meningitis, similar kind of thing. So they may go for SLA typing for younger high risk patients. Okay? Even the risk stratification is coming up. How can you stratify the risk? I hope you know what is SLA typing from your second year pathophysiology.
So human leukocyte antigen.
True. It's a human leukocyte antigen. Based on it, you can identify the person variation in immune system. You can even sometimes these are done before transplant, okay, to match the MHC class. So diagnostic method of importance. Let's see some of these method what we saw and their importance. Bone marrow aspirate. You can aspirate the bone marrow and see their morphology. And this is the special type of stain called as Ramnowski stain. And with the help of this, they can see the blast, they can see the maturing cells, and they can recognize the dysplasia. Okay, how the cell is proliferating. And cytochemistry, they can determine what lineage is involved if they do the cytochemistry, whether it is myelin or lymphoid. In immunophenotyping, they can define the blast cell lineage again whether it is lymphoid, myeloid, or biphenotype. In cytogenetics and molecular studies like FISH and PCR. Have you heard of this FISH? This is fluorescence in situ hybridization. Okay, these are tests by the help of which you can map the genetic material in person's cell. Okay, you can figure out the genetic material in the person's cell, and this is used to visualize the specific gene for a specific person. Okay, in a specific person, in a specific portion of the chromosome, they can see the gene with the help of this FISH. And sometimes like HER2 gene in breast cancer, I was talking about HER2 positive, HER2 negative. So these things are, can be able to distinguish with this FISH only. Okay, so this is called fluorescence in situ hybridization. PCR, I hope you know, that's polymerase chain reaction. This all helps in chromosomal detection of chromosomal abnormality, and based on this, they can predict the prognosis. Okay, they can tell how the disease is going to progress. This is how the blood film of normal patient looks. Okay, all the cells you can see uniformly distributed of uniform size. Okay, another slide again, so it shows you the a little bit magnified picture of the normal film. But this is the normal bone marrow cells. Okay, this was the normal blood film. This is the normal bone marrow cell where you are seeing the myelocytes and metamyelocytes, erythroblast. Like these are the difference between myelocyte and metamyelocyte. You can see metamyelocyte is in dividing stage. Okay, these are divided, but myelocyte is like not a dividing stage. Segmented neutrophil. Here you are able to see the two segmented neutrophil. Lymphocyte over here, and these are the erythroblast. This is how the AML looks under the microscope. Okay, you can see the large. I was telling you the size of the cells in the morning, whether the normal cell will be having in large in size or small in size. Rajan, normal cell will be large in size or small in size?
So it will be large.
Okay,
Normal cells will be in smaller size, and that immature cells will be in a larger, larger size.
correct. So because I was telling you, I have given you example of RBC. Okay, RBC have 7 micron diameter, but if you see the reticulocytes, these are larger cells because they are immature cells. They are not well differentiated and still in the process of dividing. So similarly here, you're seeing how big the cells are. Even here you can see the cells for the AML, and these are over rods, and these have needle-like bodies in the cytoplasm of the myeloblast, and these are because of abnormal fusion of these primary granules. These are again clump of plasma cells, most of which are small with a deep basically blue cytoplasm. Two cells are in the center, which are partially smoked and saw paler cytoplasm and less dense and staining nuclear chromatin. So AML in M4 leukemia generally this is 100 times zoomed image. These are 4 immature monocytes. Okay, two of the cells are shading in large, and the cytoplasmic fragments which can resemble like megathrombocytes or platelets, but these are not actually these are the monocytes. These are especially seen in M5 stage of M5 classification. Okay, so for ML now we look the prognostic factor. Okay, prognostic factor of acute myeloid leukemia. So how how the patient is going to do? What are the factors based on which we can decide this thing? So we'll see that. Okay, if the patient is above 50 years, then we cannot expect much of the complete remission. Okay, complete remission will fall down if the patient age is patient is elderly, like age is more than 50 years. Okay, when you see at the cytogenetics, there are 3 risk group identified. This is what I was telling you about. You can identify the risk stratification. You can give the prognosis. You can talk about prognostic factor based on these cytogenetics. Okay, good risk, intermediate risk, poor risk. Patient who have this T821 translocation. These things are translocation. Okay, these things are translocation. Here T821 means there is a translocation between 8 and 21 chromosome. Okay, so T1517 means between 15 and 17 chromosome. So you get a better picture of this when I talk about BCR ABL gene in the coming part of my lecture. There you will get how this happens. I hope you know what is P and what is Q from your +2. Anybody, what is P and what is Q? Okay, so if you see the chromosome, at least can you tell the part of chromosome, how the chromosome looks? Forgot? You don't remember? Tell me. Remember or not?
So DNA molecules is packed into the thread-like structure called in chromosome, sir.
Correct. Right. These are the thread-like structure. Okay, fine. Anything else?
It's divided into 3 parts like centromere and arm and telomere.
Correct. This is what I want. So these are the parts: centromere, arm, and telomere. Okay. So telomere is again a part of arm only, isn't it? So basically centromere and arms. Okay. And again, if you see arms, you have you have a longer arm and you have smaller arm. Okay. I'm opening a picture. I will show you that. So here is a picture. Can you see?
Yes, sir.
So this is a centromere at the center, and you have a P arm, shorter arm, and you have a Q longer arm. So this is just the basic thing. I don't want you to make it more complex and get confused. You just understand that these are translocation. Okay, this is what has been like substitution has happened, kind of not exactly mutation, but translocation of the gene from one chromosome to another. So based on that, we can stratify the risk, and this study is cytogenetic. So coming to treatment response, how the treatment response will be like the patients who have um, greater than 20% of blast cell in the marrow. This is how we have defined the AML. So if they have greater than 20% of blast cells in the marrow, the first course of treatment will have short remission and poor overall survival, because there are too much of blast cell. That means like prognosis is poor. In secondary ML, patients with ML following chemotherapy or myelodysplasia will respond very poorly. And the patients who have trilineage myelodysplasia, okay, trilineage myelodysplasia means 3 line is involved. So if such is the case, then there again is a chances of lower remission rate. So if the patient is given intensive chemotherapy, if the patient is less than 55-year-old, there is chances of 80% remission. If the patient is greater than 55-year-old, there is again progressive reduction in remission rate. This is what I was telling about the age factor in the prognosis. Bone marrow transplantation. Again, these are 2 types. In the coming I will tell you how autologous transplant differs from allogenic allogeneic transplant, and this reduce the relapse rate, this transplant, and importance of cytogenetics, as we saw now, how you can predict the prognosis. Importance of cytogenesis for prognosis in children and adults is better if they are like less than 55-year-old, and there is good risk cytogenetic group. Here we show no good risk, poor risk in the last slide. In the good risk, intermediate risk, poor risk. So if they are under the good risk, there is chances that 91% remission will happen and 65% 5-year survival rate. So I think again this autologous and allogeneic transplant you can recall from your pathophysiology, second year pathophysiology, what is autologous transplant and what is allogeneic transplant. Yes, anyone? Autologous transplant is the transplant from the person's own stem cell, okay? Whereas allogeneic, you have to match the SLA, MFC, and then the closely related person of that recipient. We choose a proper donor and then the transplant. Clear? Then coming to acute ALL prognosis, okay. Poor prognostic factor are if the patient age is less than 2 years and if the patient age is greater than 10 years, okay. If that means if the patient doesn't fall between 3 years to 9 years or 2 years to 10 years, if the patient age is 2 years to 10 years, they are much well the prognosis is much better, okay. They can much well respond to the therapy and they can be recovered very quickly. But if the patient is less than 2 years and greater than 10 years, then they are considered as high risk patient. The prognosis is not that great. Even the male sex patient, if the patient is male, then prognosis is poor. The patient have very high WBC count, greater than 50 into 10 to the power 10 per liter. That is, I think, 50 lakh, right? This per liter, okay, per liter. But what is the normal WBC count?
4,000 to 11,000, sir.
4,000 to 11,000 what?
Per microliter.
Yes, per microliter, okay. And this is here in per liter. So you can easily convert this 10 to the power 9 into microliter. If you divide by 10 to the power 3, it will go in milliliter. If you do, that means if you do by 10 to the power 6, it will go into microliter. So it will become 10 to the power 3, okay, 3 per microliter. So 3.4. So if it is like that, if it is going like high WBC count, then poor prognosis. If there is presence of CNS disease, that again have poor prognosis. And as you saw, based on cytogenetics, you can define poor risk and good risk. Okay, so based on that also you can predict the prognosis. And bone marrow, if you're seeing the blast cell on the day 14th after treatment, okay, that means there is poor prognosis for this patient. And on day 28, if you are seeing no complete remission or no complete response, then definitely the prognosis is poor. So this is how ALL looks, okay, acute lymphoblastic leukemia. This is the bone marrow, smear of bone marrow. You will see now treatment of acute leukemia. We have a specific therapy, specific chemotherapy and supportive therapy. So we treat the leukemia in 3 stages. Okay. Again, there were some 4 to 5 stages, but all these are now consolidated and made into 3 stages: induction, consolidation, and maintenance. Okay, we'll see what is induction, what is consolidation, and what is maintenance. These are the stages of chemotherapy. Okay. So induction is obtained by using very high dose of chemotherapy. Here, severe bone marrow hyperplasia will be seen, and then we'll allow the regrowth of normal residual stem cell to regrow than the leukemic cells. Then remission will be achieved only if there is normal neutrophil count back to the normal, and then if the platelet count is back to the normal, and if hemoglobin is back to the normal. How are we defining remission? Remission we are defining as if there is less than 5% blast in the bone marrow. If you are seeing less than 5% blast in the bone marrow, then we say that this is in remission phase. Coming to consolidation, we use same drug that we use in the induction, or sometimes different drug. Here we give the high dose of chemotherapy again, and the advantage of using consolidation phase is that it will delay the relapse and it will improve the survival. Maintenance, here you use a small dose of drug but for a longer period of time, and this produces low neutrophil count and platelet count. And the purpose of using this maintenance therapy is to eradicate any remaining leukemic cells. Now coming to the supportive care, you should have vascular access, central line. If required, you may have to use that for the support of the patient, by giving supportive treatment. Then you have to give some of the anti-emetic drugs for preventing vomiting. Then you also have to be ready with the blood products, like patient may have severe anemia or very severe thrombocytopenia, so you may have to be ready with those products and give when required. And as you are using highly immunosuppressive chemotherapy, so you have to be ready with the antibiotics for the management of infection, and of course the management of metabolic complication, because the